Endocarditis. Infective Theodore B. Flom. Du. Fackhoff Samantha Farron Gottlieb. Du. MS Basics. Infective endocarditis is a non-contagious infection of the heart, including valves, native or prosthetic, the endocardium and septal defects. Infective endocarditis occurs worldwide and is generally fatal if left untreated. Description: an infection of the valvular, primarily, and/or mural, rarely, endocardium system, affected, cardiovascular, endocrine/metabolic, hematologic/lymphatic, immunologic, pulmonary, renal/urologic, skin/exocrine, neurologic. Synonym: bacterial endocarditis, subacute bacterial endocarditis, SBE, acute bacterial endocarditis, AB. Epidemiology: more common in males, 3:1. 50% of cases occur in individuals over the age of 50. Incidence rose in the United States from 11/100,000 in 2000 to 15/100,000 in 2011. 1.53% incidence 1 year after prosthetic valve replacement, 3.6% 5 years post-replacement. Increasing incidence of cardiovascular device-related infections due to higher frequency of implantable devices, especially in the elderly, can be community or hospital-acquired. Etiology and pathophysiology: AB. Staphylococcus aureus, Streptococcus groups A, B, C, G, Streptococcus pneumoniae, Staphylococcus lugdunensis, Enterococcus species. Gram-positive, Haemophilus influenza or parainfluenza, Neisseria gonorrhoeae. Gram-negative, SBE, alpha hemolytic streptococci, viridans group Strep, Streptococcus bovis, Enterococcus species, S. aureus, Staphylococcus epidermidis. Gram-positive, Hassic organisms, Haemophilus aphrophilus or paraphrophilus, Actinobacillus, Aggregatibacter, Actinomycetum comitans, Cardiobacterium hominis, Ignella corr odens, King-Ella King-E. Endocarditis in 4 drug abusers, tricuspid valve S. aureus, Enterococcus species. Gram-positive, Pseudomonas aeruginosa, Burkholderia cepacia, other bacilli. Gram-negative, Candida species. Early prosthetic valve endocarditis, 60 days after valve implantation S. aureus, S. epidermidis. Gram-positive, gram-negative bacilli, fungi, Candida species, Aspergillus species. Late prosthetic valve endocarditis, greater than 60 days after valve implantation alpha hemolytic streptococci, Enterococcus species, S. epidermidis. Gram-positive, Candida species, Aspergillus species. Culture-negative endocarditis, 10% of cases, Bartonella quintana, homeless, Brucella species, fungi, Coxiella burnetii, Q fever, Chlamydia trachomatis, Chlamydophila psittaci, Hassic organisms, Abiotrophia, formerly vitamin B6 deficient streptococci, use of antibiotics prior to blood cultures. Device-related endocarditis, coagulase-negative staphylococci or S. aureus. Risk factors: injection drug use, for catheterization, certain malignancies, colon cancer, poor dentition, chronic hemodialysis. High risk with prosthetic cardiac valve, implantable devices, pacemaker, automatic implantable cardioverter defibrillator AICD, total parenteral nutrition. Previous infective endocarditis, i.e., congenital heart disease, CHD, unrepaired cyanotic CHD, including palliative shunts and conduits, repaired CHD with prosthetic device during the first 6 months, repaired CHD with residual defects at or near prosthetic site, cardiac transplant with valvulopathy. 1. B. General prevention. Good oral hygiene. Antibiotic prophylaxis is only recommended for high-risk cardiac conditions. 1. B. Prosthetic heart valve, history of endocarditis, transplant with abnormal valvular function, CHD. See risk factors. Procedures requiring prophylaxis: oral/upper respiratory tract, any manipulation of gingival tissue or periapical region of teeth or perforation of the oral mucosa. 1b. Invasive respiratory procedures involving incision, or biopsy of the respiratory mucosa merit prophylaxis. Amoxicillin 2 grams po, if penicillin allergic, clindamycin 600 mg po, 30 to 60 minutes before procedure, or ampicillin 2 grams 4/IM are first-line prophylactic choices. For penicillin allergic patients, use clindamycin 600 mg 4, or cephalexin 2 grams po, or azithromycin/clarithromycin 500 mg po, or cefazolin/ceftriaxone 1 gram 4/IM 30 minutes before procedure. Pediatric doses are amoxicillin 50 mg/kg po, max 2 grams, cephalexin 50 mg/kg po, max 2 grams, clindamycin 20 mg/kg po, max 600 mg, and ampicillin or ceftriaxone 50 mg/kg, maximum 1 gram, IM/4. GI/GU, only consider coverage for enterococcus, with penicillin, ampicillin, piperacillin, or vancomycin, for patients with an established infection undergoing procedures. 1b. Cardiac valvular surgery or placement of prosthetic intracardiac/intravascular materials, perioperative cefazolin 1 to 2 grams for 30 minutes preoperative, or vancomycin 15 mg/kg, maximum 1 gram, penicillin allergic patients, 60 minutes preoperative. 1b. Skin, incision and drainage of infected tissue, use agents active against skin pathogens, e.g., cefazolin 1 to 2 grams for Q8H or vancomycin 15 mg/kg Q12H, max 1 gram, if penicillin allergic or if methicillin resistant S. aureus, MRSA, suspected. Commonly associated conditions: infectious agents have an affinity for defective tissue. Therefore, most patients with infective endocarditis have pre-existing conditions/procedures such as structural heart disease, valvular disease, congenital heart disease, prosthetic heart valves, transcatheter aortic valve replacement, intravascular device, and cardiac implantable electronic device. Patients with a history of endocarditis also have an increased risk for recurrence due to the damaged tissue from the previous infection. Patients undergoing chronic hemodialysis have an increased occurrence of infective endocarditis due to increased frequency of introduction of foreign material into the body. HIV is commonly associated with infective endocarditis due to immunocompromised state. Diagnosis: modified Duke criteria. 1b. Definite, 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria, possible, 1 major and 1 minor or 3 minor criteria. Major clinical criteria: positive blood culture, isolation of typical microorganism for i.e. from 2 separate blood cultures, or persistently positive blood culture, single positive blood culture for C. burnetii or anti-phase 1 IgG antibody titer 1:800, positive echocardiogram, presence of vegetation, abscess, or new partial dehiscence of prosthetic valve, must be performed rapidly if IE is suspected. New valvular regurgitation, change in pre-existing murmur not sufficient, minor criteria: predisposing heart condition or for drug use, fever greater than or equal to 38.0 degrees C, 100.4 degrees Fahrenheit, vascular phenomena, major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, Janeway lesions, immunologic phenomena, glomerulonephritis, Osler nodes, Roth spots, rheumatoid factor, RF, microbiologic evidence, positive blood culture not a major criterion, excluding single positive cultures for coagulase negative staphylococci in organisms that do not cause endocarditis, or serologic evidence of infection likely to cause, i.e. history: fever, 38 degrees C, chills, cough, dyspnea, orthopnea, especially in subacute endocarditis, night sweats, weight loss, fatigue. Review risk factors. Symptoms of transient ischemic attack, cerebrovascular accident, CVA, or myocardial infarction, MI, On presentation physical exam most patients with IE have new murmur or a change in an existing murmur. Signs of heart failure, RALS, edema, are common if valve function is compromised. Peripheral stigmata of IE, splinter hemorrhages in fingernail beds, osselar nodes on fleshy portions of extremities, Roth spot retinal hemorrhages, Janeway lesions, cutaneous evidence of septic emboli, palatal or conjunctival petechiae, splenomegaly, hematuria, due to emboli or glomerulonephritis, neurologic findings consistent with CVA, such as visual loss, motor weakness, and aphasia. Differential diagnosis. Fever of unknown origin, infected central venous catheter, merontic endocarditis, connective tissue diseases, intra-abdominal infections, rheumatic fever, salmonellosis, brucellosis, malignancy, tuberculosis, atrial septic thrombophlebitis. Diagnostic tests and interpretation. If not critically ill, 3 sets of blood cultures drawn greater than 2 hours apart from different sites before administration of antibiotics. If acutely ill, draw 3 sets of blood cultures over 1 hour prior to empiric therapy. 1a. Leukocytosis is common in acute endocarditis. Anemia, decreased C3, C4, CH50, and RF in subacute endocarditis. ESR, C-reactive protein, CRP, hematuria, microscopic or macroscopic. Consider serologies for chlamydia, Q fever, Legionella, and Bartonella in culture-negative endocarditis. Transthoracic, TT, or transesophageal echocardiogram, T preferred, should be performed as soon as IE is suspected. 1a. CT scan may help locate embolic abscesses, e.g., spleen. Vegetations are composed of platelets, fibrin, and colonies of microorganisms. Destruction of valvular endocardium, perforation of valve leaflets, rupture of chordae tendineae, abscesses of myocardium, rupture of sinus of Valsalva, and pericarditis may occur. Emboli, abscesses, and/or infarction of any system immune complex. Glomerulonephritis treatment. Medication. First line. Start empiric treatment after 3 sets of blood cultures have been drawn. Results guide treatment. Native valves. Ampicillin sulbactam 12g/day 4 divided into 4 doses with gentamicin 3 mg/kg/day 4/IM in 2 or 3 doses. If penicillin allergic, use vancomycin 30 mg/kg/day 4 in 2 doses with gentamicin 3 mg/kg/day 4/IM in 2 or 3 doses, and with ciprofloxacin 1000 mg/day PO or 800 mg/day 4 in 2 doses. 2a. Prosthetic valves. Vancomycin 30 mg/kg/day 4 in 2 doses with gentamicin 3 mg/kg/day 4/IM in 2 doses, and rifampin 1200 mg/day PO in 2 doses, if 12 months post-surgery. If greater than 12 months, use native valve regimen. 2a. Penicillin susceptible viridans streptococci or S. bovis native valve. Penicillin G12 to 18 million use/day 4 continuously or in 4 to 6 doses, or ceftriaxone 2g/day 4/IM in 1 dose, both for 4 weeks. 1b. Prosthetic valve. Penicillin G24 million use/day 4 continuously or in 4 to 6 doses for 6 weeks, or ceftriaxone 2g/day 4/IM in 1 dose plus or minus gentamicin 3 mg/kg 4/IM Q24H for 2 weeks. Peak gentamicin level 3 μg/ml and trough 1 μg/ml. 1b. Penicillin resistant viridans streptococci or S. bovis native valve. Penicillin G24 million use/day 4, either continuously or in 4 to 6 equally divided doses, and gentamicin 3 mg/kg 4/IM Q24H for 2 weeks. Peak gentamicin level 3 μg/ml and trough 1 μg/ml. 1b. Prosthetic valve. Penicillin G24 million use/day 4, either continuously or in 4 to 6 equally divided doses, or ceftriaxone 2g/day 4/IM in 1 dose for 6 weeks, and gentamicin 3 mg/kg 4/IM Q24H for 2 weeks. Peak gentamicin level 3 μg/ml and trough 1 μg/ml. 1. B. Staphylococcus native. Valve. Oxacillin or nafcillin 12 grams 4/day in 4 to 6 equally divided doses for 6 weeks. For oxacillin-resistant strains, use vancomycin 15 mg/kg/day 4Q12H for 6 weeks for goal trough of 15 to 20 μg/ml. 1. B. Prosthetic valve. Oxacillin or nafcillin 12g/day 4 in 4 to 6 doses and rifampin 300 mg 4/PO-Q8H, for 6 weeks, plus gentamicin 3 mg/kg/day 4 for first 2 weeks, peak gentamicin level 3 μg/ml and trough 1 μg/ml. For oxacillin-resistant strains, use vancomycin 15 mg/kg 4Q12H, plus rifampin 300 mg 4/PO-Q8H, both for 6 weeks, plus gentamicin 3 mg/kg/day 4/IM in 2 to 3 doses for the first 2 weeks, peak gentamicin level 3 μg/ml and trough 1 μg/ml. 1. B. Penicillin-sensitive enterococcus, native or prosthetic valve. Ampicillin 2 grams 4Q4H or penicillin G 18 to 30 million U/day 4 continuously or in 6 doses and gentamicin 3 mg/kg 4Q8H for 4 to 6 weeks, peak gentamicin level 3 μg/ml and trough 1 μg/ml. 1. B. Consider expert consultation for penicillin-resistant enterococci. Hassic organisms. Ceftriaxone 2 grams IM or 4Q24H for 4 weeks. 1. B. Or ampicillin sulbactam 12 grams 4Q4H for 4 weeks or ciprofloxacin 1g/day PO or 800 mg/day 4 in 2 equally divided doses for 4 weeks. 1. B. Cardiac device-related endocarditis. Device removal followed by antibiotic therapy based on organism susceptibility. 3. B. Precautions. Adjust dosage of penicillin G, gentamicin, cefazolin, ampicillin, ampicillin/sulbactam, ciprofloxacin, and vancomycin in patients with renal impairment. Rapid infusion of vancomycin 1 hour may cause red man syndrome due to histamine release, not an allergic reaction. Treat with antihistamines and decrease infusion rate. Interactions. Vancomycin and gentamicin increases renal toxicity. Rifampin alters warfarin and oral hypoglycemic metabolism. Second line for patients allergic to penicillin, penicillin susceptible or resistant viridans group streptococci or S. bovis, vancomycin 30 mg/kg/day, not to exceed 2g/day, 4 in 2 equal doses for 4 weeks, 6 weeks for prosthetic valve endocarditis, for goal trough of 10 to 15 μg/ml. 1. B. Enterococcus, native or prosthetic valve. Desensitization to penicillin should be considered. Vancomycin 15 mg/kg, usual dose, 1 gram, 4Q12H and gentamicin or streptomycin, peak gentamicin level 3 μg/ml and trough 1 μg/ml, for 4 to 6 weeks, 6 weeks for prosthetic valve endocarditis. 1. B. Staphylococcus of native valve. Cefazolin 2 grams 4Q8H, not to be used in patients with immediate type hypersensitivity to penicillin, for 6 weeks or vancomycin 30 mg/kg, usual dose, 1 gram, 4Q12H for a goal trough of 15 to 20 μg/ml for 6 weeks. 1. B. Surgery/other procedures. Surgery is required in 50% of IE cases. Indications. 2. A. Heart failure due to aortic or mitral valve disease. Prevention of embolism. Aortic or mitral valve vegetations greater than 10 mm with prior embolic episodes. Isolated very large vegetation greater than 15 mm. In patients with major ischemic stroke, surgery is delayed for at least 4 weeks, if possible. 4. C. Uncontrolled infection, persistent fever and positive cultures greater than 7 to 10 days. Infection caused by fungi or resistant organism, presence of abscess, fistula, false aneurysm, or enlarging vegetations. Early prosthetic valve, i.e. Ongoing care follow-up recommendations. Patient monitoring. Check gentamicin peak 3 μg/ml and trough 1 μg/ml levels if used for greater than 5 days and with renal dysfunction. Perform twice weekly BUN and serum creatinine while on gentamicin. Consider audiometry baseline and follow-up during long-term aminoglycoside therapy. 2. Check vancomycin trough 15 to 20 μg/ml levels in all patients, typically prior to 4th dose. 2. B. Baseline ECG. Monitor ECG for conduction disturbances/MI in initial weeks of therapy. TTE at the conclusion of therapy. Blood cultures. Q48H until negative prognosis. The 1-year mortality of infective endocarditis is 30%. Late complications contribute to poor prognosis. These include heart failure, reinfection, and cerebral emboli. 10-year survival is 60–90%. 5a. Complications. Cerebral complications are the most frequent and severe, occurring in 15–20% of patients. 1a. Emboli, arterial, e.g., MI, mesenteric, splenic, cerebral infarction, infectious, e.g., abscesses of heart, lung, brain, meninges, bone, pericardium. Neurologic events are the most frequent complications in patients with IE requiring ICU admission. Ischemic stroke is the presenting symptom of IE in 20% of cases. 5a. Inflammatory/immune disorders, e.g., arthritis, myositis, glomerulonephritis. Other complications: congestive heart failure, CHF, ruptured valve cusp, sinus of Valsalva aneurysm, arrhythmia, and mycotic aneurysms. References 1.